Welcome to the deep dive. Today, we're on a mission that I think is critical for anyone in clinical medicine, really, no matter what your specialization is.
Mhm.
We are building a foundational toolkit, a really comprehensive clinical roadmap in pediatrics,
All right.
and we're pulling the essential facts from across the key source material, tailoring it specifically for medical students, young professionals, and, all clinical learners.
And this is a deep dive where context is just everything. I mean, pediatrics demands you integrate information so rapidly,
Definitely.
from preventative nutrition all the way to managing, say, multi-system trauma. Our goal here is to pull out the most practical, high-yield scientific nuggets.
Exactly.
One should walk away with not just facts, but the immediate clinical application for them.
Absolutely. And it's an immense field we're covering.
Yep.
We're going to start with the universal stuff, core nutrition, and the dangers of malnutrition.
Yep.
Then we'll pivot to neurodevelopment, behavioral health, and the unique risks of being an adolescent. After that, we shift into the high-stakes world of acute care, resuscitation.
And finally, we have to anchor all of it in the social, ethical, and genetic context that really it guides pediatric practice every single day.
So let's just jump right in. Segment 1, the essential building blocks of pediatric nutrition.
Okay, so when we look at the initial data on feeding, it tells a fascinating public health story.
It really does.
The sources show that breastfeeding initiation is strong. It's actually pretty high.
Yeah, it's sitting near, 79% in newborns?
Exactly. But the retention, that's the real clinical challenge that providers have to counsel families through.
That's the key stat, isn't it? Because that's where you have to intervene. By 6 months, you see that number drop by almost half, down to 49%.
And it gets worse.
By the time an infant turns 1, it's only about 27% of women still breastfeeding. So as a provider, you have to see that drop-off coming and proactively identify the barriers.
Whether they're social, practical, medical.
Right. And for infants who rely on formula, there is one fundamental fact you just have to have memorized.
The standard concentration, 20 kilocalories per ounce.
That's the baseline.
And you see this with, for example, mixing 4 scoops of a standard powdered formula into 8 ounces of water. It's crucial because you're often calculating caloric density for ketchup growth or maybe volume restriction.
It's also vital to know when breastfeeding is medically contraindicated for the mother.
Sure.
We're talking active infections like tuberculosis, varicella, or a herpes simplex infection right on the breast.
And then, of course, there's a severe recreational drug use, PCP, cocaine, amphetamines.
Right. And importantly, in developed industrialized countries where there are safe alternatives, HIV is also listed as a contraindication for maternal breastfeeding.
So once we move past just appropriate feeding, we have to confront the deficiencies, specifically protein energy malnutrition, or PEM. And the sources highlight these two, classic but very distinct clinical presentations.
And this is a classic distinction you see on the boards, in the clinic,
Right.
everywhere. Marasmus versus kwashiorkor.
Exactly.
Marasmus is the body's physiological response to, true global starvation. It's inadequate calories and inadequate nutrients. You see that severe wasting.
Correct. Kwashiorkor, though, that's a state where the child often have a fair to good overall caloric intake.
So they're getting energy.
They are, but they have a critically inadequate protein intake. And the visual giveaway is often edema.
Right, from the lack of oncotic pressure.
Precisely. No circulating protein. Both are incredibly severe and lead to, very high-stakes complications.
And those complications are immediately life-threatening. You have to monitor for a huge susceptibility to serious infection. We're talking sepsis, pneumonia, gastroenteritis.
Their compensatory mechanisms are just gone.
Totally. So you prioritize preventing hypoglycemia and hypothermia because those signal a severe systemic shutdown.
And you can't forget the micronutrients. Vitamin A and zinc deficiencies are incredibly common in malnutrition.
And they have a huge impact on morbidity.
A drastic impact. They just tank the immune function. And the sources are very clear. If this malnutrition happens during a key growth window, in utero, infancy, or adolescence, it risks permanent growth stunting.
And most critically, impaired cognitive function if it happens during infancy.
Absolutely.
Okay, so shifting to older children, dietary guidance is just as crucial. Cow's milk shouldn't come in until 12 months.
Right.
And for that next year, until age 2, you want low-fat, 2%, or whole milk. They need that fat for neurological development.
And after age 2 is when the switch is usually made to fat-free or 1% milk.
And here is a very, very common trap for practitioners, the milk baby.
Oh, yes.
You have to warn parents of toddlers about excessive milk intake.
It's so important. If a toddler is drinking more than, say, 24 ounces a day, it can cause iron deficiency anemia.
Because it displaces iron-rich solid foods.
Exactly. And less commonly, it can even lead to intestinal blood loss from a milk protein-induced colitis.
So let's close this segment on the opposite problem. Childhood obesity. I mean, we know American kids consume far too much salt.
Way too much. The recommended daily intake is 1,900 to 2,300 milligrams.
And this is tied into these poor dietary habits that are just contributing to alarming obesity trends.
The prevalence has more than doubled in children and quadrupled in adolescents over the last 3 decades,
Quadruple.
reaching a staggering 39% prevalence in the 6 to 19 age group back in 2012. And it's strongly associated with a sedentary lifestyle. The source data gives this really sobering threshold.
Which is?
Some children are spending over 7.5 hours per day in front of screens.
7.5 hours. That number, that's your intervention point. That's when you have to counsel on physical activity and limiting screen time.
That's it.
And that's a perfect transition from physical health right into neurodevelopment.
It is seamless in pediatrics.
The sources emphasize that developmental and behavioral problems are incredibly common. Only acute infections and trauma rank higher.
And given that about 15% of children ages 3 to 7 have a developmental disability, surveillance is attentive.
Every single office visit.
Every single one. And that surveillance requires knowing the uniform sequence of milestones by heart.
You have to trace that developmental arc. So by 6 months, an infant should be sitting alone.
Right.
And have fine motor skills like transferring an object hand to hand, plus pre-language skills like babbling.
And then by 12 months, we're expecting gross motor movement like walking and the ability to, say, put a block in a cup and drink from a cup.
Okay, so when a delay happens, especially a language delay, the differential is wide.
Very wide. It could be intellectual disability, social deprivation, autism, oral motor issues.
But clinically, the first thing you have to rule out is the most treatable cause.
A hearing deficit.
Always. Which is why universal newborn hearing screening is such a critical, mandated public health success.
Okay, let's talk about the risks that define adolescence. We'll say ages 10 to 25.
This population faces just immense health challenges.
And if you look at the leading causes of death in this age group, they're fundamentally different from younger kids.
Totally different. Accidents or unintentional injuries are number one.
Followed by suicide, then assaults or homicide, malignant neoplasms, and then congenital malformations.
That mortality list is just, it's so sobering. It really underscores that shift from illness to external risk factors.
Exactly. And the morbidity changes too. So while respiratory illnesses dominate hospitalizations for kids aged 1 to 9.
For adolescents, it's mental illness. That becomes the most common reason for admission.
Yes. And when you look at substance use, while there are some overall declines, the prevalence is still high. We're talking 36% to 50% of high school students report drinking alcohol.
Wow.
And an interesting data point from 2014, teens reported using electronic nicotine delivery systems, EDS or e-cigarettes, more than any other traditional tobacco product.
A trend we know has only exploded since then.
Great.
So let's get into treatment specifics, starting with anxiety. Anxiety disorders affect 5 to 10% of this population.
For mild to moderate cases, the first line, evidence-based treatment, is talk therapy.
Specifically cognitive behavioral therapy, CBT.
CBT, combined with psychoeducation. If medication is needed, it's the SSRIs. Fluoxetine, sertraline, and fluvoxamine are the ones FDA approved for kids.
And there's a critical clinical pearl here.
Oh, this is a big one. You have to warn patients and their parents that when you start an SSRI, it can initially make the anxiety or panic symptoms worse.
Before the therapeutic effect kicks in.
Right, and that's a common reason people stop the medication early if they aren't warned about it.
Okay, moving to depression. Major depressive disorder requires 2 weeks of symptoms. But you have to watch out for the classic presentation.
It's different in kids.
In youth, that depressed mood often shows up as irritability, or just a complaint of pervasive boredom.
And declining school performance is often the first objective sign that something is really, really wrong.
Finally, let's touch on bipolar and cyclothymic disorder.
Cyclothymic disorder can present early, a mean age of onset of 6.5 years, and it has a strong comorbidity with ADHD.
This is a huge therapeutic consideration.
Crucial. You must stabilize the underlying mood disorder, with a mood stabilizer before you even consider treating the comorbid ADHD with stimulants.
Because if you don't...
If you start stimulants prematurely, you risk triggering a manic episode.
All right, now we transition into the high-stakes world of acute and critical care.
Okay.
Initial assessment needs immediate focus on the ABCs: airway, breathing, circulation.
Right.
But in the setting of a confirmed cardiopulmonary arrest, that sequence reverses to CAD. Chest compressions come first.
And the reason for that rapid pivot is because you're almost always fighting the same enemy in pediatrics.
Respiratory failure.
The sources stress this. Respiratory failure is the single most common cause of acute deterioration in children. You have to manage and stabilize that before anything else.
And when you're using emergency meds, especially for metabolic issues like hypoglycemia, the dosing is complex.
Very. Because both the volume and the concentration of dextrose change dramatically with age.
Wow.
For neonates, you use a larger volume but a lower concentration. So 5 to 10 milligrams of 10% dextrose.
To minimize risks from the high osmolality.
Exactly. As they grow, you shift to higher concentrations. Infants and kids get 2 to 4 milligrams of 25% dextrose, and adolescents move up to 1 to 2 milligrams of 50%.
And a quick note on resuscitation: sodium bicarbonate.
Use it judiciously. You have to make sure the patient has adequate ventilation to blow off CO2 first, or you just risk worsening the acidosis.
Okay, let's talk about shock. Requires immediate fluid resuscitation. We have 5 classifications, but...
The most common one in children by far is hypovolemic shock.
Usually from what? Vomiting, diarrhea, hemorrhage.
Typically.
Hmm.
And it's distinguished clinically by signs of dehydration or blood loss without features of heart failure or systemic sepsis.
And the immediate treatment?
Rapid volume replacement. 4V crystalloid fluid boluses of 20 milligram by. You titrate and repeat that based on the patient's response.
The other types, distributive, cardiogenic, obstructive, dissociative, they all require different strategies, but volume is almost always that first step. Okay, moving to thermal injury. Burns. The priority is still the same, isn't it?
Airway. If you even suspect an inhalation injury, you manage the airway.
Which means?
Immediately apply 100% humidified oxygen.
And the fluid calculation for burns. This is a high-stakes calculation. You just have to know.
You do. After an initial 20 millilki lactated Ringer's bolus, the total fluid over the next 24 hours is calculated with a variation of the Parkland formula.
Which is 2 to 4 millilki per percent burn.
Right. And here's the critical timing piece.
Yeah.
Half of that total estimated burn requirement must be given during the first 8 hours post-injury.
Oh, wow.
And you titrate all of this to maintain a target urine output greater than 1 ml per kilogram per hour.
Our last acute topic, toxicology.
Right.
Any child who presents with unexplained altered mental status, seizures, or cardiovascular collapse.
Must be presumed poisoned until proven otherwise.
We use toxidromes for this, right? These recognizable patterns of symptoms.
Yeah, they're a huge help. Like the cholinergic toxidrome presenting with meiosis, so pinpoint pupils, salivation, and bronchorrhea. It helps you quickly narrow down the toxic agent and get to the antidote.
And after any acute intervention, you have to address those critical electrolyte shifts.
And there's a major warning here against rapidly correcting hyponatremia.
To prevent central pontine myelinolysis, a devastating neurological complication.
Devastating. So you have to strictly limit the increase in serum sodium to less than 12 millTQL per 24 hours, especially if the hyponatremia is chronic.
Okay. This last segment brings together the legal obligations, the ethical nuances, and the genetics of pediatric care.
So important.
Let's start with the role of the physician as a mandated reporter.
Yes.
By law, in every single state, physicians must report suspected child abuse and neglect.
And it's really important to note that neglect is, statistically, the most common form of child maltreatment.
It's an omission, right? A failure to provide basic needs.
Nutrition, supervision, necessary medical care. And regarding physical abuse, abusive head trauma is the leading cause of morbidity and mortality.
So prevention efforts focus on what?
Often on providing caregivers coping techniques for, specifically, normal, intractable infant crying to prevent shaking.
Now, when we talk ethics, autonomy is central. Competent patients, usually 18 or older, have to grasp the intervention, risks, benefits, and apply their own values.
But this gets really complex with adolescents.
Very.
Adolescents who are capable of informed consent, we call them mature minors, they may consent to care for high-risk behaviors, substance abuse, sexual health.
And for optimal care, confidentiality in those settings is critical. You have to build trust.
You do, but that confidentiality is limited.
It has to be. When safety concerns come up, suicidal ideation, homicidal thoughts, or evidence of abuse, those have to be disclosed to parents.
And the best ethical practice is to communicate that boundary of limited confidentiality right up front.
Ideally, getting the teen's agreement before you make that disclosure. You just have to be prepared for that difficult conversation.
You do. Finally, let's quickly look at the genetic context.
Okay.
Newborn screening is mandated across all U.S. states for core metabolic disorders like PKU, galactosemia, congenital hypothyroidism.
And overall, about 2 to 4% of infants present with congenital malformations you can identify at birth.
And a major public health victory here involves neural tube defects, NTDs.
Their incidence has decreased by, what, 70% since 1998?
A remarkable 70%. And it's due primarily to the simple, widespread practice of supplementing food staples with folic acid.
It's incredible.
We also see these fascinating patterns in conditions like hypertrophic pyloric stenosis, HPS.
Right, it's 5 times more common in males.
It's a multifactorial genetic condition, but look at the risk difference for recurrence. If the father was affected, the risk is modest.
But if the mother was affected?
The recurrence risk for her future sons jumps to between 17 and 20%.
Wow.
That difference really highlights how complex these genetic thresholds and inheritance patterns can be and how much they impact your counseling.
So what this deep dive really underscores is that pediatric practice demands you master 2 separate skill sets at once.
Absolutely. You have to wield the hard science, the precise dosing, the burn fluid calculations, the genetic risks.
While at the same time mastering the soft skills, recognizing the impact of things like poverty, managing complex confidentiality with teens, and fulfilling your mandated reporting duties.
It's a field that spans from the really subtle signs of nutritional failure,
Wow.
like telling the difference between marasmus and kwashiorkor,
All the way to the immediate chaotic stabilization you need for pediatric shock and toxicology.
Exactly.
So to make sure this foundational knowledge sticks, let's end with a clinical scenario walkthrough, one that applies the core physiology we covered back in segment 1.
Okay, let's do it.
So, scenario. Imagine you are admitting a 1-year-old toddler. They're diagnosed with failure to thrive, and you suspect severe protein energy malnutrition. The child is stabilized, and you're starting nutritional rehabilitation.
Okay.
Here's the reflective question. Given our discussion on PEM complications, what are the 3 to 4 immediate physiological complications you must actively monitor for and work to prevent in the first 48 hours of nutritional management? Think about their vitals and basic labs.
Okay. So if you're thinking about the immediate risks of refeeding, you have to prioritize preventing hypoglycemia and hypothermia. Those are signs of metabolic collapse.
Right.
You also have to guard against acute decompensation like heart failure from a sudden fluid or solute load. And crucially, you have to address the high risk of catastrophic infection or sepsis.
Because their immune system is compromised.
Completely. Those are the immediate battles you have to fight before you can even think about long-term growth.
And that integration from metabolic risk all the way to ethical obligation, that really is the essence of pediatrics. Something for you to chew on as you continue your clinical journey.